Good turnout, guys, isn't it? Thanks for coming. Thanks for coming a bit earlier as well. First of all, a big thanks to Fowler Simmons Radiology, Neil and Sean, who are the leaders of the MSK. I think they've been open for around about 1.5 years. 3.5 years. 2.5 years. Sorry, 2.5 years. First of all, we thank them for letting out the room for us, and second for also attending as well. So how the evening is going to run is that we have 3 quite different podiatrists, one in experience, also in skill set, and the aim of the case evening is to present something from a slightly different part of the anatomy or a different type of injury, and with a radiological significance behind it as well. So Neil and Sean will give us what they see and what other imaging we can use for different pathologies. There are 3 different cases I'm going to be presenting on Achilles tendinopathy. I think Ted is going through plantar heel pain, and when Angelo arrives, I think he's doing bone stress as well. So also feel free, guys, to grab. They've been nice enough to put some drinks out and some Tim Tams and that as well, and a couple of bottles of wine as well. So feel free to go and grab some of that. So first of all, this case is a pretty close case. This person I met, he came through the clinic as a competitor of mine, and 4 years down the track, we're very good mates, and it was quite an interesting case. I guess the reason I chose this one is the treatment regime which we chose in the end was quite different to a normal treatment regime from, I guess, you would say a traditional podiatric treatment regime. So this was a self-trained athlete, which means he didn't have a coach, and quite experienced. I'm going to cover through what injuries he had previously, some of the current injuries he presenting with. I'm going to go through the basic structure and function overview and the imaging that was brought to the clinic on the first consultation, and the imaging that was done furthermore after the initial assessment. Then I'm going to go through the plan of attack from the patient's goals. And at this point through here, Ted and Angelo will also contribute as to perhaps maybe what some of the different techniques or treatments or plans that they may do for a particular case like this as well. And we'll try and interact like that throughout the evening as well. Okay, and then I'm going to go through the outcomes at the end because that's always the best bit. So this patient was a 26-year-old middle distance runner. He'd been competing for about 12 years at a very high level. Over the past 12 years, he'd been consistently running about sort of 50 to 70 kilometres a week every single week. And currently about 45 kilometres. He trained 6 to 7 days a week all the time, and he varied his sessions up. So one day he'd run fast, one day he'd run slow, other days he would go to the gym, other days he would run through the mountains, other days he would go to the track and run repetitions. So he did what he loved to do. He'd been a track runner since a high school student. Just to get an outline as to what sort of athlete he was, he ran about 48 seconds for 400 metres. He ran a 1500 in about 4:02, or about 4:17 in the miles of the old scale, and he ran a city to bay time, which everyone can relate to, at around about 39 minutes, so he's quite a handy runner. His previous injuries noted, he had one really significant lateral ankle inversion sprain. I can see Ted's eyes light up with this. And he did this when he was 14 years of age, playing football. He also had left mild to moderate iliotibial band syndrome about 2 years before this consultation, and he noted it too when he started to add more mileage. He went from running 30 k's a week to about 70 k's a week, and it cleared after around about 6 months, he said, and he didn't have too many dramas with that ever again. And 8 years ago, he had medial tibial stress syndrome and a relative stress fracture on his right side more than his left side. But more importantly, why he came in, for the past 12 to 18 months, he'd been presenting with a left pain at the back of the heel in the Achilles region. Okay, so this presented with a typical Achilles issue. People who's here had clients with an Achilles issue before? A fair few, yes. Okay, she's only about 60%. I've got a bit more than that. Anyway, so this was a typical Achilles issue. When he first got it, it took 4 or 5 minutes to warm up. 6 to 9 months down the track, it was taking about 20 to 30 minutes to warm up in his runs. He would just deal with it. He'd limp a bit for the first part of a run, and then typically in the morning he would get up and he would sort of hobble on his toes for a bit, and after about 5 or 10 minutes he'd be able to lower it down and not have too many symptoms. This went on for a long period of time, and until he started to seek treatment. And in the past sort of 12 months, he sort of sought physiotherapy for some manual therapies. He didn't go into detail, but he said he had massage, he was given some stretches, he had dry needling, he was doing general icing. He sought podiatry, and he got given a pair of EVA orthoses for daily use and for use of running. When he presented, he didn't bring them with, and he just basically said he used them to walk and used them to run, and he just chose when he chose to wear. It didn't make a difference for him at the time. He saw a sports physician for a scan eventually, and he received a cortisone and a local anaesthetic, which was unsuccessful at the time, and chose to pick 4 weeks off rest. And this for an athlete who hadn't rested much more than 2 or 3 weeks in the past 7 or 8 years. So this is the MRI that he brought with as well. So this is where I hand over to Sean and Neil to have a quick peep at this as well. But
alright, so look, this is the only image I've seen. It's the first time I've seen it. So there is obviously a lot of other things that could potentially be going on. But we have a fairly isolated image. It looks like it's proton density weighted, or you can call it T1 weighted if you like. The fat is bright. And we're getting a pretty good overview of the ankle, so we can see the plantar fascia, we can see the tibio-talar joint, subtalar joint, and obviously some of the midfoot articulations. The Achilles is, well, what stands out, at least on this image, is its uniform thickness, its uniform signal intensity. The insertion looks pretty reasonable. Little bit unsure what's going on in the superficial soft tissues between the skin and the Achilles, but the fact that the Kager's fat pad looks actually reasonably okay, probably encouraging that's just artifactual. He hasn't got a Hagelin deformity, he hasn't got fluid in his retrocranial bursa. He has got a lot of scarring and quite a large os trigonum. In addition to the os trigonum, he's got this sort of extra facet. So the os trigonum is actually articulating with the posterior margin here of the calcaneus. It looks like there's a bit of scarring here in the posterior recess of the ankle joint, and this is sort of connecting up here with the tibiofibular ligament, the posterior portion of there's sort of a meniscoid ligament that runs across the back of the ankle. You can see a portion here, but this looks like a reasonably scarred capsule. We need more.
So there's one more in the top of the MR.
Okay, let's talk to that as well.
Down.
All right. So this is the fat suppressed images. It's both images are T2 weighted if you're interested, but this one has fat suppression on. So anything that was fat before, which is the marrow and Kager's fat pad and the subcutaneous tissues, the heel, is now black. Things that are more fluid signal intensity are going to be white, and you can see the articular cartilage is somewhere in the middle there is grey. So again, Achilles is still fairly uniform in signal intensity, it's fairly uniform in thickness. There's a slither of fluid, but that's physiological, and that's in the deep retrocranial bursa. There's a bit of fluid and a bit of scarring in the posterior recess of the ankle joint there. And here we've got some little bit of cystic change between posterior aspect of the calcaneus and the os trigonum there. So, and the marrow signal intensity, this is normal marrow signal intensity, and this is a little bit higher. So it's suggesting you've got a bit of an edema process going on within it, and that would suggest that there may be a degree of impingement. Some of these aren't impinging, some of these are degenerative pseudoarthrosis, because this synchondrosis can be unstable, and you'll get degeneration between those two areas. And sometimes it's a pinch-off thing in a plantar flex position where that's what's catching everything at the back as well. So it really depends on what they're doing and how they're doing it as to why you get the posterior impingement. But things are pointing more to posterior impingement there than Achilles, because the Achilles looks pretty pristine.
And just before you go on,
yes.
T2 weighted,
yes.
Can you just explain what that means?
It's a physics term with regards to how. So MR is obtained by putting into a magnet. The magnet is always on. Okay, your body's made up of water mostly, and water is mostly made up of hydrogen, which is mostly protons. So you align all your protons. The way we get the images is to excite those protons, and then watch how they relax. And the relaxation of those protons can be measured in a number of different ways. And one of them is T1, and one is T2. There are different other ways as well. But with regards to MR imaging, the sort of classic things everyone used to say was T1 weighting was what we used to see for the anatomical images, which was where you could see the anatomy and the fat was bright, and T2 was where fluid was bright and you saw the pathology. The difference now is it's changed because or at least as musculoskeletal images, we've sort of thrown away T1 because it doesn't really add much that you don't see from a non-fat suppressed proton density weighted image. So proton density is a form of T2 weighting. And again, you're playing with the factors, and it's all too complex physics to try to explain easily, and with my fading memory on how to explain it. But there are ways to suppress the fat out by putting pre-pulses in. So this gets the fat out, and that just changes the whole dynamic range of the image. Those two images actually is pretty much similar, other than this has got T2, a pre-pulse in that actually gets the fat out of the image. So the dynamic range of the image has changed. So what was dark before is now bright because everything else is black.
Great. So there's nothing to do with a weight bearing or semi-weight bearing.
No. Weighting is all about how the image is acquired and what's in there.
Okay. And so this image, was it taken in just a relaxed position?
Yeah. It looks like it's been taken in an ankle coil because the foot is in a fairly neutral position, but non-weight bearing clearly.
Yeah.
And because the foot's not plantar flexed, it must be in sort of a chimney sort of coil. So a lot of the coils, and there wouldn't be anyone probably using the old coils now. They used to try to use the knee coil, which meant you had to sort of plantar flex your foot to get it in.
Okay.
And it made it hard to get down here, and you got all the artifact. This is sort of essentially obtained supine, foot in a comfortable neutral position, essentially.
Okay. Good. Thank you.
And as Sean said, from the image, the ostrigonum and the synchondrocus instability became the major focus of the treatment regime with what he was dealing with. When he presented to me, he also mentioned that he had an ultrasound done, which I've got the image of that coming up, that was done to try and guide a corticosteroid injection into the Achilles tendon area. He definitely presented in the area where if you plantar flex the foot or a forced plantar flexion, he had no pain at the back where the ostrigonum was, and he had no pain on palpation back there, but there was distinct pain on the Achilles tendon with the squeeze test. That was his major issue. So he was 6 weeks out of his national titles, and he decided to get another injection done. And this second injection was done under ultrasound with huge success into the Cargan's fat pad and the paratenon and the deep retrocalcaneal bursa. And he had minimal to no pain for a period of around about 6 to 8 weeks. So the general assessment, he had pain on the squeeze test. So you would squeeze the part of his Achilles tendon about 2 centimetres up, a typical site for Achilles tendinopathy. It would hurt. He had no pain on the forced plantar flexion. His tendon was slightly thicker on the left and the right hand side, but he had a lot of strength. He could hop, but with pain. And the one thing that was most notable when he was hopping is that he did land a lot more flat-footed, as he didn't want to get up onto his toes, until he did 4 or 5 of them. It warmed up and then he got back up there. So he'd been going through this for about 6 to 9 months. And still at this point in time, it was taking about 30 minutes to warm up. The one thing he did note is that there was less pain on the long run, which was his Sunday long run, and it was much worse when he was in racing flats and spikes, which we'll go through in a second. He couldn't train consistently at a quality pace, so he refused to run slow often, so he decided to just miss training altogether, and he was training 2 or 3 times a week, and hard 2 or 3 times a week, and trying to recover. This was the ultrasound image that was presented. I'm assuming this is the deep fibres of the tendon. I'll let Sean have a look at this through here, but I think this was the ultrasound that was used to guide the injection as well.
With the MR image, we obviously have just an isolated image, and the MR image may be not representative of what the ultrasound is showing, but the ultrasound certainly, if you rotate it around 90 degrees, now we've got the Achilles tendon going this way rather than this way. Here's where the retrocalcaneal bursa was, and here's the posterior margin of the calcaneus at the enthesis there. The difference on this is that it's not uniform thickness. It does actually become fusiform expanded, and there is a focus of, we can see here you've got nice little linear fibrillar pattern of the Achilles, which is what you expect to see. On this deep aspect, close to the insertion, it's not the typical location we see the mid-Achilles tendinosis, and it's not the real typical location we see the insertional tendinosis either. So this is sort of a deep aspect stuff. You might see this in someone with a Hagelin deformity, probably more regularly, the deep aspect close to the insertion. But here we've got the fusiform expansion, which is more typical of the mid, and this altered echogenicity and loss of that sort of linear thing. You can see the nice lines running through there of the tendon. This is just all little dots and blackness there. So there's clearly a focal area of tendinosis within that deep aspect of Achilles.
This is the training basis.
So this is an axial image. So we've just turned it around 90 degrees, looking at it end on, and you can see that they've lined it out quite nicely. And so you've got this tiny little rounded focus. If you gave me that isolation, didn't label, I'd tell you that's proximal patellotendinosis and it's jumper's knee, because that's exactly where that occurs. Deep central aspect, and it often has that sort of swelling on the deep aspect as well. So here we can see the tendon quite nicely, and just the other area is just altered in its appearance, in that it's darker, and it's certainly, the contour changes in that region, which is not normal. Normally you expect the superficial surface to be slightly convex, and the undersurface to be slightly concave in an Achilles tendon, so that one's obviously bowing out on the undersurface.
Brilliant. So the report came back, grade, it was said to be, actually it was wrong here, so it said it was an unusual grade 2 tendinopathy. Location-wise. And to me, this became the major focus of the treatment regime. To me personally, he wasn't having too many issues with the os trigonum, but he was getting issues that painted the picture of a local tendon pain. I'll go through my assessment. It's very overview. I will go through it in 3 different categories. I'll go through some of the function, some of the structure, and then I'll go through the dosage. So in a non-weight bearing assessment, he had we draw the line, he had a medially deviated subtalar joint axis, the left and right. So the left was within normal limits, the right was deviated, the left was the Achilles symptom issue. He had a 5-to-1 inversion to eversion. His ankles were so lax, but the left one would keep going. He had previous avulsions of his lateral ATFL and CFL ligaments. The right one wasn't as bad. He had injured that 3 or 4 times, but he had avulsions of the left side. In the weight-bearing assessment, when he was standing, it was quite hard to create a windlass mechanism on his left-hand side. The right was very responsive and easy to respond. The supination resistance test was a bit harder on the left than the right, this being all subjective, and his lunge test was notably a bit more on the right hand side than it was on the left hand side, so there was about 10 degrees difference between it. He said he felt stiffer on the left hand side. When we start looking at the proximal, when he started doing his one-legged stand test, he had a left Trendelenburg gait, which he had a contralateral drop, and this became a lot more defined when he became dynamic. So the biggest dynamic things I noticed with him, when he would do some calf taps through here, his left one was quite sloppy, so he wasn't very reactive, whereas the right one had really good timing on the ground. If he jumped for 20 seconds continually, his right side was just pat, 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 whereas his left was really, the knee would flex more, the ankle would flex more as well, and he didn't have a lot of response. So when he went running, and we put him at around about easy pace then to this threshold sort of pace, so we judged him as what he was running out for his easy pace, which was about 14.5 kilometres per hour, and on the frontal plane gait, his left side of his body would definitely have a high Trendelenburg gait. Funnily enough, normally when you see some of the articles about forefoot striking and the higher risk of Achilles tendinopathy, he had developed a gait on the left-hand side where he would almost rear foot strike on the left-hand side, but he'd land on the forefoot on the right-hand side. The biggest attribute is he had this he's the sort of runner you would see from a distance. He made running look easy. He had this nice vertical osculation when he ran, a really bouncy spring, a really low strides per minute. So he's about 160 strides per minute, which is quite a lopey sort of gait for someone who's about 6 foot as well. But as he would strike on the left-hand side, he would land a lot further out in front of his centre of mass. I did have a video, but it just didn't upload very well. I should have used present. And then he sat down, and so what happened on the right side, he'd land beneath his body on his forefoot, and it was this really nice timing. You know how you see a golf swing? It just made this really nice noise. On the left-hand side, it didn't make a noise. It was swallowed. So he basically hit the heel, it collapsed through here, and his knee would flex over the top, and a lot more tensile strain on the posterior part of the calf. But he didn't know he was doing it. Footwear-wise, he wore a performance trainer, so the Zoom Elite. Does everyone know their footwear pretty well? The footwear that he wore was very much a low lightweight sort of shoe, almost on the verge of being a minimal type shoe for almost every single run that he did. He just preferred the feeling of it. So, and all the spikes and the tempo shoes, they're all more or less the similar sort of shoe. His weekly regime. Now, I did a data analysis. He was self-coached, but he used Garmin Connect. Has anyone used Garmin Connect or an application like Map My Run before, or Strava? And they're really good, so you can grab all the data. So he gave me 9 months of data, and I was eating lunch one day, and I was looking through he had a typical training week. He had an easy run Monday, Wednesday, Friday sometimes, and he had a quality long rep session on Tuesday, which means he ran like mile reps continually. He had a threshold run, which was like a run at City to Bay pace. And then on Saturday he had he had a speed session, and Sunday his long run. But the long run was done with a group. What I've marked here are the easy runs, the Monday, the Wednesday, and the Friday. Now, the notable issue with the load here is that I could not believe it. His PB for the City to Bay was about 39 minutes, and his Monday long run, which is an easy run, was about 40 minutes. Now, an easy run means you're just going for an easy run. His easy run was around about 330k pace or 340k pace, which wasn't far above what he was doing for his easy runs. When he did his Tuesday run, which was like a threshold run, there was only about 320k pace or 315, which is about what it was meant to be for what he was training for. But the Wednesday was the same. The Wednesday, one of his Monday runs, he ran 11.9k's in 40 minutes, which is almost his City to Bay time through the hills. And Wednesday was very similar. He ran about 30 minutes at the same pace. So suddenly, he was running the same pace almost 4 days a week, continually. And when someone comes in and says, I do an easy 40, it's all relative. So sometimes it's important to grab the data or work out what is your easy 40 minutes. Do you run, a little bit slower, or do you run a bit faster? The long run, which was less painful, was with the group. And when you run with a group, you go with the group set. And he ran about 425 to 440 minute K pace. And he pulled up the next day feeling okay. And okay during that run. So there was no preparation for calf or Achilles loading in his gym program. He did a typical push-pull squat, so you do some bench press, some lat pull downs and some squat, but no running drill focus. He would just run and do a bit of strength in between. So this became, to me, a person in need of structure. So his major goal was to continue to compete and train consistently. After 3 or 4 visits to the sports physician, he said, we can always take the Austrigonum out. And he said, well, I'd rather my golf day start than get surgery. So he was pretty keen to not get surgery and try something different. And the second goal was basically just to get back onto the road for improvement. He'd been doing the sport for 12 years. He was losing enjoyment for it. So we put in a plan of attack, and we looked at some of the function through there. When you follow some of the research and you look at the Trendelenburg gait and its influence on the lower limb chain in terms of internal rotation, we looked at giving him some gluteal strength to add into his gym regime. We looked at progressively loading his gastric soleal complex. This was after a 2-week phase when his off-season was off, and what we did with that is that we gave him some basic eccentric movements with body weight, where he was going up and down on single legs. This became progressively more difficult it became more intense as the loading went on. So he followed the point of pain. So he could handle eccentric loading, suddenly moved to ballistic stuff. So suddenly he was trying to get a little bit more dynamic eccentric loading. And then second to that, he moved into doing it with a bit of resistance. And then finally, he moved into doing running drills, which is sort of your halfway or your bridging point. So you would do some high knee drills and some skip drills to try and load the tendon without pain. So we also gave him the cue to try and stop being as vertically osculated when he was running, to run slower to the ground. He did run like a spring when he ran, and there's a good article done by, I think it's at the end, who put all the different types of gaits, people who are very sit down when they run, so horizontal gait versus vertical osculation, and looked at the different types of pathologies they get. And those who tend to be very vertically osculated got a lot more posterior calf and Achilles issues. So we just sat him down a bit more, and that took a while, and by doing this we increased his strides per minute. Now, 2 years later, he's down to around, he's up to around about 168 strides per minute. It's not a massive change, but it seems to have done the job. We've shifted him over to when he does his long runs to wear heavies. Now, for 2 reasons. The heavies are basically your traditional shoes. They're structured into structured cushioning, your neutrals, and still some companies call it motion control, with a slightly higher heel raise, and he would wear them when he did his slow and easy runs. He did not wear his orthoses. When he did his tempo run, he wore his racing flats, which he was already wearing. And when he did his track work, he still wore racing flats without wearing running spikes. He wore running spikes once every 4 weeks. The big thing we changed is the load. We slowed down his easy runs. And as far as I'm concerned, after about 8 or 9 years, all the people that I see with Achilles injuries, when they start to get these injuries, they're running pretty well, and they're running pretty well often. You look at all the great distance runners, they all seem to retire from Achilles tendinopathy, so usually it's a faster running injury. And Nielsen et al. Looked at categorising injuries, and his average speed throughout the whole week looked to be something like around about 350k pace, and now his average speed is around about 420k pace, so his slow runs are about 430k pace. But then he focused on running quality twice a week, but the other 3 or 4 weeks really slow. Now, this may think, well, if he's not running hard every single day, how is he going to improve? How is he going to get his goals? What has happened is that he's traditionally gone through years of just getting really good training blocks in and then getting injured. And the one thing as far as I'm concerned, if you're not injured, you're going to be improving. So, 6 weeks, we progressed him into easy running. He did nothing but easy running. He ran at 430k pace for 6 weeks, and this killed him. He used the GPS to do it. He didn't go really above the pace or below the pace. He was just around about the mark. During this phase is when we added the progressive tendon loading in the gym, and we did it 3 or 4 times a week with him. And then by the end of it, he didn't have much discomfort. He had slight discomfort in the running drills. They're quite high intensive. But after around about 6 to 8 weeks, we added in his tempo running and his interval running. And he can move into that really, really comfortably without too much pain. But we didn't do anything drastic. He didn't hit the track. He didn't wear his running spikes. He was still wearing his heavier shoes. And then at week 16, we added this repetition work in, which basically is the faster quality work again. And he had minimal pain through the progression, and he'd never trained like that before. But he did question how fit he was. He was training quite slower than he remembers it was worth doing. But he had trained consistently for 24 weeks in a row. He had 9 months of pain-free running completely. Now I think it's around about 17 months. He still continually does gastric sleeve and gluteal strengthening regime in the warm-up of his gym work. His long runs are still taken pretty easy. His mileage is up to about 90 to 110 k's per week. And this year he ran the Cedar Bay 37 minutes. It was a good example of, and obviously his 400 didn't change because the type of training has changed. I think when you get to 27, 28, your training has to change a little bit. But in saying that, he does less quality. So if you were to grab all his data, which I did after 9 months, and look at his metre per second average, it's dropped from around about 7 metres per second average for some of his training sessions back to around about 5.4. So when you look at some of the Nielsen et al. Studies and they look at Achilles issues, it has this nice correlation between how fast you're training. Now, every individual is different. So for example, if you go to Kenya, yes, you run a marathon in 2 hours and 2 minutes, for example, your easy run might be 350 pace. But at the end of the day, they are relative, but you need to prepare your body to handle these stresses. So this was a good example of a person who we just basically altered the load. And as you're all aware, the Achilles tendon research over the past 5 to 10 years has probably been built on load more than structure and function. So this was a really, really useful case. And but yeah, any questions? Angelo? No. There you go.
To me, the ultrasound was the most convincing pathology that we had there. The osteogonum that was there isn't necessarily symptomatic. And,
No.
And you said he had an abnormal squeeze test, so it sounded like the
It painted a picture straight away as an Achilles issue.
It was always an Achilles issue, so the osteogonum was a red herring.
In the original MRI, it mentioned that there was some tendon irregularity, but it wasn't significant. And so it became the treatment regime with his osteogonum, because he was quite vague on describing what he was doing. The sports physician assumed that because he was sprinting more often than not, that the continual plantar flexion was creating the nutcracker effect on the synchondrosis. But his only pain was so local to the tendon, it painted a picture of a typical tendinopathy, which became loading.
I think the warning there is that the imaging is not, some things that stand out aren't the cause of the symptoms. They certainly have to be correlated with clinical findings. The other thing is ultrasound, particularly for superficial tendons, will give you a lot more detail than MRI. MRI seems like the expensive technology and the be all and end all. Ultrasound, particularly for the more superficial tendons, hands, anything around the feet and ankle, and really, average sized person, shoulders, elbows, etc. The ultrasound for tendons is a hell of a lot better than MRI. MRI shows you the joint stuff and the bone stuff really well. It doesn't show you the tendons.
It's been brilliant for Achilles and MPSopathies and paratenons and separating your typical inflammatory issues with your tendon.
I was chucking something when I was at the Olympics in Sydney. I kept the record every time I scanned. I did about 70 scans on sportsmen, and the biggest one was Achilles across every discipline in sport. Weightlifters, runners, didn't know who they were, bloody pole vaulters, hockey players. It was all Achilles. Achilles was number one by miles.
Got to have an Achilles issue to be good.
Yeah, but that was the fascinating thing, that it was actually Achilles.
Yeah.
Number one by a mile.
So to me, it paints the picture of a really quality running injury. So sometimes someone comes in with your running injury, and what I would see is your typical person running 3 times a week for the City to Bay, especially in June, July. They'll run the same pace, the same shoes, the same course 3 times a week, and there's no variation in the training whatsoever. So you get the same load continually. And the pace they'll run at will be about race pace, which will be the template. I'm going to run 60 minutes at City to Bay, I'm going to run a 5-minute K pace 5 times a week. If I ran at race pace, that 3 or 4 times a week, I too would probably get an injury with Achilles issue as well. It's just like when you run long, slow mileage below race pace, there's a high incidence of patellofemoral pain syndrome, iliotibial band syndrome as well. When you start to run fast, it just disappears. Start loading the carbs. Achilles. Vary your training.
So what are the key clinical tests that you did or you would recommend us do?
Yep.
Because you mentioned about there was no pain on the plantar flexion. So
there was a pain on the squeeze test. So
yes.
just the squeeze test, the hop test. So I used to just put one leg gently on a box of about 20 centimetres and just get him to hop 3 or 4 times, and I would compare the left and right. I'd look for timing, see how efficient he is on one side, and see if the foot position was quite symmetrical left and right. And the left one would definitely sink more, and the right one had a really good timing. He'd keep his heel off the ground really, really well. So I looked at the lunge test as an indicator of stiffness, but the squeeze test was enough when the imaging was done. So when I saw the imaging and the squeeze test, like Sean said, sometimes you get that, that ostrigonum back there with all the fluid. It looks like a dog's breakfast. That wasn't his issue, and still today isn't his issue. So the squeeze test was a big one, single hopping test, and then the big one was the history of which type of running was causing the problem, and it was never the longer running and the easy running, and his gait substantially changed to this really bouncy, loping gait when he had to pick the pace up.
when he had the cortisone under ultrasound,
Yep.
where was the ultrasound actually deposited? Because from the images it looked like it was going to be
The cortisone
deeper.
was deposited in the retrocapillary bursa, Kager's fat pad, and the communicator with the paratenon.
Yeah, I didn't see the,
Yeah.
the injection side of things, but if they were injecting the Achilles, they probably would have just placed the needle sort of along the undersurface of the Achilles tendon, and just if you put it on the dorsal surface, the more superficial surface, you'll be able to strip the paratenon quite nicely because it just comes off the tendon. On the deep aspect, you've got the fibrofatty sort of changes along the base, and it sort of just blobs there, but you can strip off some of that blob. But a lot of when you've got abnormal tendinosis and you've got abnormal vessels coming into the tendon, they usually come from that deep aspect as well. So sometimes part of what you're trying to inject them is to try and separate that sort of abnormal neurovascular ingrowth off from the abnormal tendon substance. And just by putting nothing in, but just stripping those off, it will give you pain relief often because it disrupts those abnormal nerve fibres that are actually the pain, carrying the pain.
And he had nice 6 to 8 weeks of success with that.
You did it with saline.
Yeah.
A big relief. So.
Is the profit margin better on saline versus cortisone?
I think saline might cost us about 50 cents and cortisone $5, so probably it is, but it doesn't come into consideration.
Oh, it doesn't? Oh.
Not normally, because we'll just charge it the same either way.
Thanks, guys.
I don't know if this actually changes anyone's treatment, because obviously I'm a podiatrist or a physio, but one paper that came across our desks probably 3 or 4 years ago was just determining the zonal anatomy of the Achilles tendon, and it's probably more relevant for Achilles tendinosis, and this was probably sort of mid to distal, but determining some people's Achilles tendons are sort of just diffusely abnormal, but other times you'll just see the change of tendinosis are zonally placed, like the one we saw there before. It was just along the deep undersurface of it. And when you follow the tendons down, some people you can actually quite nicely make out the components from the soleus, lateral gastrocs, and the various part of medial gastrocs. So if it's of relevance to people, certainly ask, because I could imagine if we say that this tendinosis was coming from the fibres of the lateral gastrocs, and if it somehow changed how you were going to manage them, then it's actually fairly easy to do it from that.
So it spirals down, basically.
It spirals down, yeah. And you will see tendinosis patterns which are sort of primarily soleal or primarily lateral gastrocs quite regularly. So anyway, I thought it was an interesting paper, but I didn't know what to do with it.
Save it for us.
In the talar carpineal joint. The talar carpineal joint is the subtalar joint. Now, just in terms of history for this case study, it's a 50-year-old male who had pain that was sort of recalcitrant, had increasing sustained edema of the left foot and ankle for some 6 months duration. And it was actually made worse after a traumatic episode where he'd been in a sidecar attached to a motorbike and hit a guardrail. So the pain with the foot certainly increased in intensity, but also had some trauma to the knee, which was addressed orthopaedically, and he had some operations in that respect. Now, when he came to see me, he reported pain at quite a high intensity of 8 out of 10 with normal walking. He was on his feet for long periods of time, and there was also rest pain associated with the condition. Previous treatment was basically Panadol from the GP and Voltaren, and then just over-the-counter orthotics. So in terms of the type of pain, you described it as a shooting, stabbing, sort of burning pain. Didn't have any rheumatological conditions. The doctor's x-rays didn't show any fracture or any significant bone involvement. His daily activities is that he was self-employed. He had a VIP business with irrigation and lawn mowing, so he was able to do administrative work, because it just said that it probably wasn't a good idea that he'd be on his feet for long durations given his presentation. Taking Panadol Osteo, and he was also a marijuana smoker, so he probably got a bit of pain relief from the natural remedy. Had allergies to codeine. In terms of examination, when he first presented, we'll usually get them to point where's the maximum site of pain, point with a finger as to where it's the sorest. And he wasn't able to do that. He was just sort of everywhere. Looking at medial, lateral ankle, posterior heel, dorsal foot, it was all over the place. I wasn't able to gauge specifically what compartment of the foot we were sort of dealing with. In terms of observation, there was some global edema of the ankle and the rear foot up to the tarsus, and just multiple sites of pain. So the Achilles was painful on palpation, both the insertion substance tibant was painful in and around the ankle, tarsal tunnel, there was just areas of pain sort of globally. So he wasn't able to perform a double heel raise. There was weakness and also pain in walking on his heels, and also pain when walking tiptoe with heel raised. So there was a lot going on, I guess, in terms of pain and multiple sites of anatomical structures that were involved here. So I was a bit lost as to what actually was going on. So I wasn't sure what the primary problem was previous to the injury, whether the accident itself created some additional injury to what was already there, or whether some of the problems were related to gait changes because of what had been going on for quite a long period of time. So what I did do was immobilised him for a period of 4 weeks in a moon boot with the cells that have got the edema control, and just to see, I guess, what improved and what didn't, so I'd have a better idea as to what I was dealing with, in terms of anatomical structures involved. So I got him to resume the use of NZ to put him on diclofenac for 7 days, and then just as he has required after that period. So in terms of clinically what he looked like when he returned after the 4 weeks is what we're seeing here. So we're not seeing the pre-foot trauma foot here. So after 4 weeks, there was a reduction in pain down to a 4, so pretty much halved. There was resolution of edema, so it did allow for a more reassessment with the pain reduction and the edema reduction. He was able to perform a double hill raise, although with some weakness. And there was more of an I was able to identify and isolate the pain more to the lateral aspect of the foot and the subtalar joint. And we can see the involvement of the left foot. In comparison to the unaffected right side, we can see that collapsing pes plantar valgus foot type, the excessive internal ankle rotation in through the ankle. You see the taut tendon there, the talar navicular bulging in through that area there, and the typical alignment of the collapsing pes plantar valgus from behind with the too many toes side. So I guess in what I'm thinking here at this point in time is that we're getting some form of lateral impingement occurring in and around the fibula, sinus tarsi, that area through there. So referred for a musculoskeletal ultrasound to have a look at the lateral ligaments and tendons in the sinus tarsi, including the subtalar joint. So where are we here? After 4 weeks mobilisation, ongoing lateral aspects of talar inferior ankle joint pain. So again, thinking of this lateral or posterior ankle joint impingement. So the musculoskeletal ultrasound didn't show any involvement of the fibularis tendons. There weren't any findings in terms of what was going on in Kager's triangle with osteogonums or the like, or synovitis in that posterior aspect of the subtalar joint. But it did show some synovitis of the subtalar joint, at which time we was often offered ultrasound guided cortisone, which he did proceed with, which is here. Now this is really putting on the spot, guys. I sort of apologise in terms of what's going on, because it looks like a total mess to us.
Can I chuck in?
Yeah.
Very common picture. What we're doing is looking into the sinus tarsi. So, there's the bone, skin's up here, and this is the sinus, which is a very characteristic, it's a hole full of fat. And the subtalar joint balloons into the side of the sinus. So that would be your subtalar joint ballooning into the sinus. You also see how the fat here, normal fat up here, is black, so it's edematous fat. So, you know, the old sinus tarsi syndrome, press the thing, they go, ow, where we press the ow. So if you're doing injecting the subtalar joint, for example, because there's fat, the fluid actually has a nice easy passage out into the sinus because it's a squishy area. So if you have a tight subtalar joint full of fluid, most of the places the fluid can't get out. But here's a nice, soft, easy landing. So the fluid preferentially comes out this way. So if you're looking to inject a subtalar joint, you often go into the joint, and then, you know, a bit down there if it's tender. So that's the subtalar joint, typical.
Okay, so yeah, it's familiar. Correct.
Neil, can you just orient me around that image when you said there's bone, there's skin? Which
Okay.
bone and what
Okay,
skin?
well there's skin, you know, stuff on the outside.
Lateral to the sinus tarsi there.
Yeah,
So,
yeah.
and you're looking down this.
Down that way.
Yeah.
So you've got
Yes, it's
that
coming across there. So that's the talus we're looking at,
Calcaneus.
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 Yep. That's the fat. So it's just the.
It's a strange view because you're you know if you're thinking of, just say the talus sitting like this, and if you're scanning along the neck of the talus, and so we're looking, and to the left of our screen is, well, if that was my hand, is the talar dome, and distally is the talar navicular joint. When you fall off it, you fall into the sinus, and so this would be posterior, that would be so that would be towards the calcaneus, that would be towards the forefoot, and you've just fallen into it, and you just fallen into the margin where the calcaneus is sort of sitting there. I mean, that could be a little bit of the talus, but probably the calcaneus and subtalar joint. and the rest is sort of subtalar ligaments, and tensor retinaculum is probably sitting through there.
So white is bone.
So this white line here is bone.
Yeah.
That is everything which is in bone. So that's the periosteal surface. This is fat, and this black area here is fluid. But it's a single image, and ultrasound is a dynamic sort of thing. So
Okay, yeah.
I could make that into about 3 other bits of the body as well, but given that we're talking about sinus tarsal,
I've got
that's
15
the
others. Okay.
So I guess with those findings, with the synovial thickening and the effusion that we're discussing here, was good enough reason, I guess, to proceed with cortisone injection, and that's what was done.
I think one of the things with subtalar effusions that are unexpected, you sort of want to know why they're there. That's a large subtalar effusion. If you've got a traumatic experience or something, you go, okay, well, and subtalar joint's one of those joints that's hard to assess with x-rays because you don't see it very well, and it's hard to assess with ultrasound because you only see the edges of it, and so there could be a lot of chondral pathology underlying it, and there could be, is it an inflammatory arthropathy, is there something going on? But, I always start, when I see large effusions that are difficult to explain based on the history, you've got to be thinking inflammatory arthropathy on one, or something going on in the bone in two, or in the chondral surface in two. So it's either osteochondral, it's marrow, or it's inflammatory, and you've got to probably have an explanation for it. So you can't just sort of say, subtalar effusion that's the cause for their pain, there's a reason for that subtalar
Correct.
effusion.
Yeah, and I guess that's the reason behind looking further into what's going on here in terms of it just being an isolated synovitis. There must be something else going on.
Sorry, Angelo, can I just ask, so you've referred for an ultrasound, do
Yes.
you refer plus or minus cortisone injection?
Yes,
or
I
is
do.
That,
Yeah.
you leave that up to?
No, I usually put plus or minus cortisone injection, and then the radiologist will discuss that requirement with the patient.
I'd say that there's, for our ultrasound referrals, like, so say from the GPs, that's pretty much what they want for almost all of them. There'll be some where they're sending along, and it's not plus or minus, it's plus. They know what they're dealing with, and they're sending along for an injection. We do a diagnostic study at the same time because they're not always right. With the podiatrists, it certainly hasn't been encouraged by Medicare for us to be offering the injection side of things, and we do. And it's rebated. We get rebated the same whether we do the injection and a diagnostic study for a podiatrist. But with a GP, there's a payment for the injection side of things. But at the moment, we just wear that sort of and go, oh, well, providing services, just quick and easy just to do it with there. The patient might be a little bit more out of pocket than if they come from a GP, but probably in the scheme of things, not very much. And often not at all. They'll be the same out of pocket as they would be with a GP. But yeah, we do a lot of injections with podiatrists.
Yeah, thanks.
Oh, sorry, next one.
So from there, in terms of improvement, there was some good improvement following the cortisone injection, but the improvement was short-lived. So within 3 to 4 weeks, there was a return in terms of the pain. So again, we know we're in the right area. There was good improvement, or not total resolution. So this then, with discussion with the radiologist, was to proceed with MR. And so MR, and you can perhaps talk to us about what the findings are on MR.
I think it's again an isolated image. If we were to orientate, we're heading out the lateral aspect because we're into the sinus tarsi here. We're seeing the posterior facet. We're seeing the tibio-talar joint. This is the margin of the sinus tarsi here. We're going to get close. There's cuboid. If we come out a little bit more laterally, we're going to get to the anterior process of the calcaneus there. There's a little bit of fluid sitting here at the front of the posterior facet of the subtalar joint. The articular cartilage looks quite nice there. There's not much out the back. There's a little osteogonum there. But what we're seeing, this is a PD weighted fat suppressed image again. So it's T2 weighted, it's got fat suppression. What is bright is tendon, more fluid, more protons. In this marrow, there's abnormal signal intensity. It's marrow edema. So marrow edema occurs in lots of different pathologies, and I'll probably not say what I think this is until Angelo gets to talk a bit more. But it tends to indicate something's going on with the bone, and sometimes it indicates something going on with the adjacent soft tissues. but in this instance it's on both sides of the roof and the floor of the sinus tarsi there. So,
Yeah.
So just checking, that white area is more fluid.
yeah, so there's
In
subcutaneous
between the
edema
joint.
across the dorsal aspect of the foot.
Yeah.
There's a tiny little bit of fluid in the joint here. This is the cortical bone of
Yes.
the talus as it forms the roof of the sinus tarsi. This is the floor of the sinus tarsi. The dark area again is the cortical bone. This is sort of normal marrow, and this is obviously contiguous with the rest of the calcaneus.
Yes.
And that high signal intensity is not what I expect to see. I can see it with red marrow.
Okay, so this is not the problem. This is what you're talking
Well,
about.
this is what we saw on ultrasound. That's the fluid in the that's the fluid in the
Yep.
anterior recess of the subtalar joint.
Okay.
But is this causing this, or is this causing that? That's the chicken and egg story.
Oh, okay. All right. Yes, thanks.
Yeah. Thanks. So I guess just in terms of the discussion of bone marrow edema and just reviewing the literature, because I've not seen a lot of cases in terms of bone marrow edema in the foot. I've had enough cases in the navicular, and I think you guys see it in the knee quite a bit. And I'm not actually sure whether bone marrow edema is just something that's come about with MRI, or whether bone marrow edema was diagnosed previously with other modalities. Can you shed any light on that, guys? Is it?
Bone marrow edema is probably more. It's a bugbear of mine because it means a lot of different things, and if I lean it one way, that pushes the clinician to do one thing. If I lean it another way, it pushes them to do something completely different. So, but all it means is that there's abnormal amount of protons in that area. It's probably more bone marrow high signal intensity. You can't determine whether marrow has edema in it, because by the time you fix bone, let bone soften, put it on a slide, the edema's gone. So it's not something you can prove with histology. You can't show that there's more fluid there. You have subcutaneous edema, that's fine. You can show that exists. But in bone, you can't, because you've got to soften the bone to actually cut it, to put it on a slide to make any useful information out of it. So pathophysiologically, it's not edema, it's something completely different. But it's indicative of a number of pathologies. So in someone who has bone marrow edema in an acute trauma setting, it's bone bruising, it's microtrabecular fractures. In someone who has something in the foot, and we see it a lot in the foot, it's someone who has a stress fracture, where they're presenting exactly like a stress fracture, their bone will become edematous. It's a microtrabecular fracture, but not due to a one-off injury, it's a more chronic injury. You see it in the setting of reactive edema, because someone has inflammatory arthropathy and erosions that will cause edema, and you'll also see it when bones impinge on each other, so one's whacking into the other one. That's sort of a chronic stress, not a stress fracture as such. And you'll also see it in degenerative change. So in someone with osteoarthritis and no articular cartilage, the marrow goes under change and there's fibrovascular ingrowth, and that becomes high signal intensity. So that's bone marrow edema. So there's lots of different things. They all mean different things. They all present differently. And if you call them all bone bruising, you're wrong. If you call them all stress fractures, you're wrong. It really has to fit in with the clinical picture, and it has to fit in with the rest of the imaging.
And I guess when you sort of look into it as to why we get bone marrow edema, and in terms of avascularity and blood supply and necrosis, it start to get a little bit nervous, because then you're starting to talk about avascular necrosis and sort of in bone death. So bone marrow. Yeah, it's back. Yeah. So I guess leave it at that. In terms of treatment, I guess the first off management is just I treat it as pretty much as a fracture, even though it's not a fracture, severe soft tissue involvement as well. So that's basically rest and immobilisation. So we were either a non-weight bearing cast, I used a moon boot, a cam walker, and then followed up after the 6 weeks with stable footwear and a splint, an orthotic splint, to help stabilise that collapsing pes plano valgus. Because I guess my rationalisation for this injury or this presentation is bony impingement, and it may well have been aggravated by the injury. I'm not sure of that. But in terms of some of the evidence regarding foot orthotics and the impact that foot orthoses have in terms of modifying the distribution of trabecular injury and bone and edema, well, there's a good study that was done here in this in Australia, looking at bone marrow lesions, but this wasn't actually through the subtalar joint. Bone marrow lesions were through the navicular and the tarsus. But it was interesting in terms of this study where they used a sham orthotic and a normal orthotic as a comparison and found that the orthotics did actually reduce the bone marrow lesions after a period of 3 months, so looking at the volume of these lesions. So it's nice to see that mechanical loading can be altered through our impacts with orthotics and footwear therapy. So this is just, I guess, a little bit of evidence that we can change some of those internal forces through that. So I guess in terms of further treatment, if this patient fails to respond as to what I would expect them to do over the next, say, 3 or 4 months of addressing the mechanical aspects of the problem, do we then start to consider it as a delayed or non-union, and treat it maybe with bone stimulation to get bone growth? Let's start let's get some stimulation occurring in terms of bone growth, or is it more of an osteoporotic type of involvement where, again, this is still, I'd imagine, considered experimental for this condition, but biophosphonates, intravenous biophosphonates, to try to bump up the calcium and trabecular growth within that region. So there's other things that we need to consider, and obviously the involvement of the medical community to see whether or not we can get further improvement in the patient's presentation if what we do doesn't improve as we would expect it to. Now, I think with the prostacyclins and biophosphonates, I think they're given intravenously with some of the cancer patients, which some of the cancer drugs strip bone of calcium. So I think that's used in that setting, but in the setting that I'm presenting with, it's not typical. Thanks. Did you want any comments?
The biphosphonates are used in stress fracture situations, in various situations, particularly those people who've demonstrated low bone density, and you'll see that in young athletes. Young, I mean 40, 50-year-old athletes. There shouldn't be osteoporotic males, etc. They're presenting with femoral neck stress fractures or iliac stress fractures.
A couple of athletes I was with in Finland, they were taking bisphosphonates through a nasal spray in Scandinavia for stress reactions, and finding rather than 8-week tibial stress, they were coming back with about 3.5 to 4 weeks.
Yeah, it is used. There is some concerns with regards to biphosphonates, though. There's an unusually large number of patients presenting with, and these are biphosphonates on patients with osteoporosis as well. So people with osteoporosis will be without fractures, but at risk of fractures, will be given biphosphonates, and there's an unusually large number of people presenting with subtrochanteric fractures of their proximal femur, and they're all on biphosphonates, and so something's altering something that making these things occur. So you certainly can't be too liberal with it. Probably, athletes without a good stress fracture probably shouldn't go on it, but I'm not saying they don't do it, but it's probably, you've got to have a really good reason for it. The biphosphonates aren't, without their side effects, and a subtrochanteric stress fracture gets fixed with a bloody big intermedullary rod, so you don't want one of those. You've got to be careful. But stress fractures are certainly treated with biphosphonates now, and it's a reasonable thing. In feet, stress fractures and stress responses are probably that's the most common area we see. We probably diagnose 1 or 2 a day, and obviously most of them are, they're just standard people who just do too much and break a metatarsal. But you'll see it in cuboids, you'll see it in calcaneus, you'll see it in navicular. So they are really, really common. And, there's different ways of looking at them.
Or I guess if something like this was to continue, then orthopaedic referral, if it doesn't resolve, so you see in terms of drilling and core decompression to, in essence, sort of drain the edema. I guess it's a condition that you need to keep monitoring to ensure that it does in fact resolve and doesn't push through to the next level, which is avascular necrosis. So we don't want to see that particular joint collapsing and get condyle damage and severe deformity as a result of that. So I guess in this patient, I would certainly be monitoring to ensure that he does progress as I would expect him to progress. And maybe would you suggest reviewing MR again to see,
This one's a difficult one, and without knowing a lot about the patient, to me, I look at this is an egg rather than a chicken, and marrow edema, stress fractures, avascular necrosis has been a bugbear of mine for 14, 15 years now, and the literature is super confused, and the reports you'll get from people will be super confused because they'll just read what the last paper had, and it's really confusing. The way I've put it in my own head to get my head around it is, let's just assume that avascular necrosis exists in renal transplant patients and people who are on high-dose steroids for a long period of time. You don't get avascular necrosis otherwise, okay? So let's ignore that one. There are lots of things that get called avascular necrosis, but they're stress fractures, okay? So spontaneous osteonecrosis of the knee, distal talus avascular necrosis, they're just stress fractures, okay? So let's call those stress fractures. They're not stress fractures because that person ran 40 kilometres, they're just stress fractures because the biomechanics through that distal talus, etc. In this instance, they're developing a stress response, not necessarily a stress fracture, but I would actually call this a bone impingement between the roof and the floor of the sinus tarsi, because as soon as this person stands up, the talus slips forward, the bones impinge on each other, they go into that hindfoot valgus, they're probably impinging their calcaneus and their fibula at the same time, we can't see that image, and they're developing stress, but I still think this, though a cause for symptoms, is probably reflective of something else that's causing them to go into hindfoot valgus rather than this causing them to go into hindfoot valgus. So this is a sinus tarsi impingement, but without seeing the other images, something else is causing that. But that is contributing to the symptoms, there's no doubt. The coring, etc., the coring of bone came from the concept that people who had developed femoral head marrow edema had an early phase avascular necrosis, because that's where we see our most common avascular necrosis. That's where the renal transplant patients get their avascular necrosis. What I think the literature probably hasn't fully explained, but probably has demonstrated through multiple papers, is that the changes within the femoral head in those people who haven't got avascular necrosis, but a lot of edema, and we used to call this transient osteoporosis of the hip or transient marrow edema, is that they have a stress fracture. And you can get subarticular stress fractures in the femoral head, just as you can get in the distal navicular, and probably coring them probably made sure that they rested, which made sure that they recovered from their stress fracture. So yeah, don't send them to the orthopods because their understanding of the condition is probably less than it should be. But at the same stage, marrow edema, like I said before, is really frustrating because that could be degenerative, that could be a stress fracture, that could be infection. But it is a response within the bone, it's a response to trauma, but it's probably a response to long-standing impingement, and probably I think it's an egg.
Okay, thank you. Okay, so I guess, I guess bone marrow edema shouldn't be overlooked as a possible etiology of, chronic unrelenting foot pain. It's something to be considered. And then I had a couple of questions to you guys. Yeah, if a patient does present, and does have multiple sites of pain, is imaging something that is helpful in that scenario?
Yeah. I don't think a lot of patients report their symptoms all that well. They sort of go, oh, it's a bit here, it's a bit here. But obviously, the beauty of ultrasound is that we actually get to examine the patients as well, and you guys do it. You guys can push us in the right direction. We'll examine where you ask us to, but we'll probably examine where we want to as well. And that's where ultrasound's quite useful. In MRI, it's not quite as easy because we just have to do what you tell us and, well, approximately where you say the problem is, and then we may track that a little bit further, but oftentimes will prevent us from going much further because by the time I've seen the images, the patient's already left. So imaging in diffuse pain is actually not easy, but I think one of the beauties of feet is often they're not diffuse pain, they're sort of, I'm sore here. So that's where image is good. Diffuse pain, it takes a little bit longer, but if you play with them, they may have more than one site for causes, and that's not uncommon. So it is useful. That one thing I've covered, I don't think, I wouldn't worry about AVM, and just think of it as a fracture and treat it as a fracture, you're probably going to go okay. And yeah, look, yes, look. This, if you think about this now, this still has an issue. Whiplash, no one knows what's causing it. You know, we're imagining it's soft tissue and ligamentous injuries. A lot of those are going to be bone bruises in the cervical spine, in the facet joints and things like that. We don't do the resolution required to make that diagnosis, but if you're willing to spend an hour on every patient and really res up everything, you're going to start seeing these little subarticular bone bruising things. Yes, the bone bruise is definitely a lot more common diagnosis now. It isn't just a microtrabecular fracture, it's the same thing. I think one of the things that's really pertinent to the feet is, and this is where I got myself really confused with it, is in the feet you see someone present with a marrow edema in the proximal talus, and then you see them, and then come back 3 months later it was in their distal talus, and then it was in their calcaneus, and then it was in another bone, and you're going, and there's this condition called transient migratory marrow edema, and you're going, well they must have that. They're just getting stress factors in different locations because essentially you're resting from one, you're getting back up, and suddenly you're putting different stresses, different biomechanics through, and another bone goes, and every time you rest you're losing bones, so it just keeps going. So they're all fractures. And they take a while. I don't know how to treat them, but I can tell you what the diagnosis is. Most of them are fractures, and this transient osteoporosis, it's a weird diagnosis. If I talk about a 40-year-old male who's a runner, who shouldn't have osteoporosis, who presents with a subarticular fracture of his femoral head, because that's where transient osteoporosis of the hip tends to occur. I don't know why it occurs, but it does. So there's something's happened in there, you know, maybe it was a virus, maybe it was something happened, but then they developed a fracture. Really common in pregnancy. You know, pregnancy does so much to your body. You know, it's caused enough to resorb some bone from your femoral head to cause you to fracture there. So you know, that's my general philosophy. But you caught a bugbear of mine, that was.
Yeah, well, it's good because I was confused.
How do you go?
The point is that it's a really, really confusing topic, and I would, if you see things like stress fracture, that's part of a continuum. But when you start seeing avascular necrosis or things like that, or osteonecrosis, which means the same thing, start to question a little bit, because it's probably, even like radiology reports, it will be a lack of understanding of the disease, because, you know, if you see my reports from 7 or 8 years ago, ignore them, because they're probably wrong.
One of the beauties of doing feet, which makes it interesting from my point of view, is there are several misconceptions. One of which is any problem has to be the cause of every symptom. So you guys know better than anyone that most feet over the age of 50, about 7 things wrong with them. And that is the issue. They, you know, have this sort of pain here, pain there, numbness here, and if you go thinking, well, is it a tarsal tunnel condition? So you look at, you know, Chris might say, numbness, tingling in the toes, query tarsal tunnel. Look in tarsal tunnel, she's good. Now that's the difference between the football terms, the 1%ers. The astronauters are really, you know, they know their subject. They sort of say, if they don't, I say, well, what about the mortals neuroma? What do you mean the mortals neuroma? Well, there's probably got about 3 of them. You know, stir them up. No. Okay, take pictures of it. So there's a 2, 3 and a 3, 4. You squeeze the 3, 4. Like, oh shit! Then what about the plantar plates? Oh yeah, okay. Torn too. And you look at the feet, and the second and third toes are diverging, and they've got a hallux valgus. You know, I mean, you can actually just look at a person walking in, you know, Goethe from the Barossa Valley, you know, very overweight, feet that you sort of give you nightmares, and it says, come and go, cree plantar fasciitis. Well, we had one today. It was pretty much that story, and yeah, she had plantar fasciitis. She also had peroneus longus underneath the foot. She had first metatarsophalangeal joint. She had tears of second and third plates, and she had neuroma. So that's the thing that, you know, medicine, you know, you have to sort of find the cause. Well, the cause is she's fat and overweight and old. If you're looking for the pathology,
Right.
there's a lot of different stuff, and that's the beauty of feet, is actually just looking at them, talking to them, and usually the sonographer's doing the talk, you know, the scanning and showing me stuff, and the fun part now that I'm older and I don't have to scan so much, is I just talk to the patient, and it's amazing what comes out.
Yeah.
You know, since I had to get the new orthotics, okay. We had a patient that actually had 3 operations from having orthotics. I'll tell you the story just as I sure as playing around.
Was that
Ultimately,
surgeon?
this person trod on glass 20 years ago, and they got a little neuroma of the medial plantar nerve just in the distal arch region. Now, they had a high arch foot, so they actually didn't really impact that area.
Oh.
So they just walked along for 20 years and didn't know had any problems. Then they went to see somebody, we'll call it a sort of podiatry person, and they gave them arch supports, which meant the orthotic was now pressing on the medial plantar nerve neuroma. So suddenly she starts getting pain in her toes. So then she goes to what we might call Dodgy Brothers Radiology, and they diagnose Morton's neuromas, 2, 3 and 3, 4. So then she goes to a surgeon who takes them out. And bugger me, she's still got the pain. So the sonographer, we're scanning along, no neuromas, no neuromas. And the sonographer's sort of talking, and we're just chatting, and the lady, and she said, oh, you know, it's ever since I've got this lump in my foot. Going, you know, so what lump? Oh, you know, this one here. And then by following that, and we said, hang on, it was Matt. He sort of, we plonked it on, there's a neuroma. Holy crap. So then we went to the story, and it actually traced the logic of it. High arch foot left alone, neuroma, happy as, orthotic press on neuroma, pain, dodgy ultrasound, not dodgy surgery, surgery's fine, just that there's nothing there. Pain persists, basically because she got an orthotic.
Yeah.
And that's the sort of the intellectual challenge of doing this, of actually getting the story. So I was sitting there, this really good sonographer scanning along, and he was doing stuff, and we just got the story out of it. And she was fascinated. She said, do you mean I had about $10,000 worth? And I said, you know, sort of, mate. But that's the sort of, that is actually the fun of feet. You know, that's what you guys do. It's actually that complex.
You guys already know feet are a lot of fun, actually. I think we do a lot of feet imaging here. It's actually a really cool part of our job, because the others aren't very good at it, and it's hard. It's a hard area. I mean, even when I was trying to learn it, trying to work out, you know, where I am while I'm scanning, you get lost, you know, oh my God, where I am, and yeah, once you get pretty good at it, it's actually, you know, and you know, they're not always pleasant, but they're usually.
Well, the other thing I might add is, of our scans, 50% are high arch feet. And there are patterns of pathology.
Yeah.
You can look at the X-ray, so oh yeah, walk in and poke them between the 3rd and 4th or 4th, 5th metatarsal bases. I say, oh shit. Boom, boom. Or perineal tendons, you know, it's all that lateral foot, or the first MTP, plantar, fat pad degeneration, or the impact points, you know, there's patterns.
Yeah.
And once you get the patterns, it's fun. Yeah.
Just before Angelo finishes up, or the topic on the bone marrow edema, this is a patient who would have presented with lateral foot pain, you know, a tender over the you know, maybe the perineal brevis or peroneus longus as it sort of extends under the joint. And don't exactly remember this patient, but the thing is, on the ultrasound, this is all occurring in the marrow. We can't see in that space, but when you look up here, this is the sort of the lateral margin of the extensor digitorum brevis. You can see how swollen that is, and you can see the swelling underneath this, and this is where they're sore. They're sore over that area. So when you're scanning with ultrasound, you actually see this swollen lateral margin of extensor digitorum brevis. You see edema along the bony interface, and you'll often see increased blood flow. And you know, do I use ultrasound to make a diagnosis of femoral neck stress fractures, which occur on the undersurface of the femoral neck? No, because you can't get in that very well. You can push there, and you go, if the story fits, you can certainly try doing it, but you're not going to be able to see it. But most people have got pretty skinny feet, and there's not much tissue between where we're scanning and where we're trying to look. You can often see the swelling on the bone surface, and so I'd say, if we're diagnosing 1 or 2 stress fractures a day, I'd say 90%, 95% of it done with ultrasound. So, and the X-rays are going to be normal. So it's not probably as sensitive as MRI, and I don't always go, well, yeah, you know, this is definitely not a stress fracture because ultrasound's negative. If it fits right, you might go, but you don't. For those people that you can make the referral for, ultrasound's not an unreasonable way of doing it.